Hi, thanks for having me. I'm Nadine Mallak, nuclear medicine and radiology faculty at Oregon Health and Science University in Portland, Oregon. So our study was in patients with biochemical recurrent prostate cancer who have had PSMA PET, and the PSMA PET failed to detect the site of recurrence. So the idea for the study, it really came from a real life experience when we know these patients have biochemical recurrence, PSA going up, we do PSMA PET and it's negative. So the idea was like, should we do Axemin scan now? Would that help? And so we designed this prospective study to look into that specifically. And so we imaged 50 patients prospectively who have biochemical recurrence with PSA more than 0.2, negative PSMA PET, and who had no anti-cancer treatment between the PSMA PET and fluciclovine PET, which happened within 30 days of each other. And what we found is in 56% of patients, we were able to detect the site of disease on the fluciclovine PET. In half of those, the disease was local recurrence in the prostate bed. In 18%, it was in regional lymph node metastases, and in 32% in distant metastatic disease. The PSMA PET is the current standard of care to localize tumor sites in the setting of biochemical recurrence, and it is superior to fluciclovine PET. So PSMA PET should be always our to-go imaging study. It's been shown to be better than fluciclovine, especially for the detection of metastatic disease. Now, the gaps, there are two potential limitations for PSMA PET. First is that the local recurrence in the prostate bed can be masked by the urinary excretion of our two most commonly used tracers, which are the gallium PSMA 11 and Pylarify or DCF-PYL. And so these two agents are excreted via urine. And so we have the bladder accumulates the agent and might mask the local recurrence. And the second potential limitation is PSMA negative disease. So we do have recurrent prostate cancer, is just not expressing PSMA. And that explains basically that 50% of our patients had disease in lymph nodes and distant metastases that were not detected with PSMA, and they were detected with fluciclovine PET. Yeah, so this is a very important question because the two agents are very different. So they have they look at different processes. So the fluciclovine PET is a synthetic amino acid, so it's taken up by prostate cancer just because prostate cancer takes up amino acid. And PSMA, it targets specifically PSMA on the surface of the cancer cells. So the interpretation criteria are very different between the two. They are luckily published. So we have published guidelines for interpreting these scans. And so for the purpose of our trial, the PSMA PET was interpreted clinically by an experienced nuclear medicine physician. So our physicians, like, they follow the guidelines for PSMA and interpreting these scans. So those were done clinically, and for the purpose of this trial, the fluciclovine PET was interpreted following strictly the recommendations of the joint EANM and SNMMI procedure guidelines. So those were published in 2020, and we followed strictly these criteria for the interpretation of our fluciclovine scans. Yeah, so the potential pitfalls or some benign entities that might show uptake on fluciclovine are different than the benign entities that can show uptake with PSMA PET. So some of them are the same, but some of them are different. The most common with fluciclovine PET, I would say, is reactive lymph nodes. So it is common to see reactive uptake in reactive lymph nodes in the groin region. So it's important to know that this is common, and this is most commonly seen with reactive nodes. So something to keep in mind. And like the interpreting physician also should be aware of this. Yeah, so I don't think that this study is particularly impactful for places where PSMA PET is not available. I think um, PSMA is the first line imaging modality for biochemically recurrent prostate cancer. And it's best to have it around. If it's not available, then fluciclovine PET for sure should be used. But I think the relevance of our study is for places who do have PSMA PET available, they image with it and they cannot localize the disease with PSMA, that basically fluciclovine is a good agent in this small subset of patients. Yeah, so it'll be good to verify these findings with larger trials, and also to look at outcomes, especially when we see change in management based on the fluciclovine PET results, to see basically how that affects outcomes. And maybe specifically what I'm talking about is the local recurrence in the prostate bed. So basically, should we do radiation anyway if we fail to detect the local recurrence in the prostate bed with fluciclovine and PSMA? Or is it safe to wait until we see something on imaging? I think that's an important question, and we do need trials to show basically what is the best approach in this setting.